My first diagnosis was major depressive disorder, and I predominantly live with bipolar affective disorder, which just means it's more depressive than it is manic. I view these all as responses to trauma, and parts of my responding to in regard to relational trauma that's ongoing in my family and community. I've had lots of experience. I've been institutionalised for a year of my life across public and private settings. I'm a current psychosocial disability user with our National Disability Insurance Scheme in Australia, which is the one of a kind. We're very lucky, and there's not many people with psychosocial disability that actually gets access to that. So I feel very fortunate and privileged to have access to funding that I can use in ways that I have choice and control over. I am not just a consumer, though. I'm also a family carer. I lost my mother to suicide at the age of 9 and lost her much longer before that to her mental health issues. Both my two younger siblings live with what psychiatry defines as schizoaffective disorder. I'm also a social work clinician. I have been in the past. I'm not anymore. I've been an insider advocate, an outsider activist in the system, and now I describe and self-describe myself as a mad activist academic. In terms of my learned expertise, I've done training and assessment and education quals. I've done the Indian Law Society International Diploma back in 2018-19, pre-pandemic. It feels like a lifetime ago. So it's lovely I've always wanted to do the Sangath training, but it just hasn't been the right time for me, but it is this year. I've trained in undergrad social work and postgrad advanced social work at University of Melbourne, and I'm currently doing a joint Masters in Public Health and PhD at the University of Sydney. And I know you're probably thinking, Matthew, what on earth are you doing? That's too much study, and you're probably right. But study has been my parent, it's been my validation, and I just love learning. I love learning and love understanding my experience and my community's experience. In terms of laboured expertise, I've worked in child protection, forensic mental health, prisons, disability advice to the courts, with veterans, counselling and group work. I've been a critical social work educator and academic for a long time. And like I said, I'm more in mad pride activism and mad studies scholarship, which focuses in critical psychiatry with a focus on lived experience people driving that research. So mad people that are identified. And obviously now I work in public health in structural commercial determinants and raising truth to power. So that's a little bit about me. Lovely Audrey Lord, there is no such thing as a single issue struggle because we don't live single issue lives. So I'm not going to go through all of this, but this is just to walk through my positionality, some of my privileges, some of my oppressions, some of my disadvantages. I think sometimes we have a bit of a misnomer in low, middle income and high income countries in terms of relative privilege and relative oppression and disadvantage. I'm someone that actually grew up in pretty severe deprivation and poverty. I was in out-of-home care and foster care for a number of years, and was, a survivor of child abuse and neglect for a long time. And then after that, had to deal with the loss of my mother. And then after that, had to deal with my sexuality, and have recently, in the last few years, come out as non-binary as well, to acknowledge my mother's spirit within me. And she drives a lot of the work that I do today. So that's my mother there. That's me in the right-hand corner at age about 7. My mother passed away 2 years later. She was only 28 years of age, Samantha. I'm not going to speak too much to my lived experience growing up because I think that's a whole other, session, and we don't have time for that. But it's just to know that there was a lot of confusion, isolation, disconnection. Growing up in foster care, you always felt like a second class kind of sibling or child. The Furby in the middle, I remember the foster children or the children of the foster parents getting presents and gifts for Christmas and us not getting any, and I always wondered why. There's a really good story that done by my local state, the Victorian Mental Illness Awareness Council, if anyone's interested, on lived experience being my superpower. That's not to acknowledge the despair, the pain, the suffering, but it's also to acknowledge that through triumph and through post-traumatic growth, we can find and harness gifts in our vulnerability. So through my madness to mad activism, I've been involved in a lot of mental health gap forums. So Shekhar, I actually was at his final mental health gap forum in 2018 when he handed over to Devora Kestel, the current director of mental health and substance abuse. So it's a funny turnaround to see him all these years later. And then through the movement for global mental health, I was at the launch of the Global Mental Health Peer Network, which was mentioned before, which was early 2019. And for the first 3 years, I was the Western Pacific regional lead of that network. I've done a lot of consulting work around for CBM and Harvard around task sharing in low and middle income countries and what peer work models and peer support models can look like in communities that are driven by community and culture, as I'm a very big believer in. I don't particularly like the word decolonization. I think decentralization is a more appropriate term because decolonization comes from race. I was also at the inaugural Global Ministerial Mental Health Summit in London, which was a very seminal and important event for a lot of health ministers that were close to, that came close to understanding what the global mental health issues were. And we heard a bit about that in the last week. So my career really kicked off back in 2018 in international mental health, where at the GAP Forum, where Shekhar was handing over to Devora. I mentioned at the end of the 2-day forum that the UN and WHO have a collective responsibility to recruit lived experience or lived expertise by experienced practitioners at high levels within organisations to undertake global strategic analysis and engage various national user and carer networks around the world, which will assist in the previous point around bringing lived experience voice and our lived experience disciplinary voice to a truly interdisciplinary perspective in mental health. So they were my final remarks at that forum. And I got a big round of applause. There weren't many of us with lived experience. You can see in the background the Japanese health minister there. It was a very high-level meeting. I found myself in the MAD movement, and MAD is, of course, a term that is contextual and quite jarring for many people in different contexts, but it's actually a word that's been reclaimed, much like queer in the queer community has been reclaimed. So the MAD movement's really a social and political movement advocating for the human rights, the dignity and empowerment of people with lived experience and neurodivergence. And it's rooted really in a critique of traditional medical and psychiatric practices that seek to medicalise and pathologise human suffering and distress, and promoting alternative understandings of mental health that centre voices and experiences of those who have been marginalised in the system. And I've had both good and bad experiences. It hasn't all been terrible, but I've had some very, very bad experiences, and I've been witnessed and privy to other people having terrible experiences in the system, including my siblings who are both on community treatment legal orders in the community. And Australia is one of the highest proponents of both electroconvulsive therapy in the world, and we are also one of the highest proponents of community treatment orders. So we institutionalise people in the community in this country, despite you thinking that it's probably a high-income country and we have a very luxurious system. It's a system that's not working, and our mental health rates have never been higher. So definitionally, constructions of madness I draw from other mad folk and people with lived and living experience. So Lamar Jarrell Bruce has a book called How to Go Mad Without Losing Your Mind, and it focuses on madness and Black radical creativity. So it has a critical race lens, which I'm sure many of you will appreciate. He talks about 4 definitions of madness: phenomenal madness, which is sort of a raw, intense unruliness of the mind, crisis of perception, emotion, meaning, and selfhood. And we might think of this as when we're going through extreme grief or existentialism, or we might be having a spiritual epiphany or awakening. And, you know, we see a lot of this in response, particularly in low and middle income countries, with spiritual leaders and guides, and often people in the community that are responding to people going through these, you know, what might be emotional or human development crises. Then there's, of course, medicalised madness, which I don't need to go into. That's the DSM and the ICD that seeks to pathologise distress as an illness or construct all distress as illness on a spectrum. The third one's quite interesting and relates particularly to people of colour, but also anyone that's really a marginalised community, including the queer community and gender diverse folk. So rage is a third definitional construction of madness, which is an affective state of intense and aggressive displeasure. And Lamar talks about Black people in the US often being criminalised as threats to public safety and lampooned as angry Black caricatures and pathologised as insane. And we heard Graham talk about that in the UK, where Black people are proportionately involuntarily detained. The fourth is psychosocial madness, which is sort of often what you think of as in terms of a personal practice that maybe just doesn't fit the norm. You know, maybe it's someone that's a bit eccentric or a bit loud and out there, but it's sort of a social construction of someone that doesn't meet the norms of society, which are often capitalistic, you know, cisnormative, heterosexual, you know, all the privileges. So I certainly feel like I fit into that. I'm a bit eccentric myself, a bit colourful. But they're really four really interesting definitions on madness. I love this, and we might use this as a stepping stone for discussion, but Elisa Riani is an art therapist and person with lived experience, and she talks about needing to dig deeper beneath the biomedical model, which is the surface. And as you can see, the layering of the medical model and pathologization, big pharma and the DSM, and that we need to use our intersectional spade of power and social justice to actually dig beneath the surface at all the cultural, the spiritual, the structural, and social determinants that actually are underlying a lot of the distress and the responses to trauma that are then pathologized on the surface with an illness or a disorder or a disease. You know, she suggests that, you know, biomedical interventions, and I would also hypothesize, do not address the root cause of a lot of people's distress or illnesses. And even things like psychosis, you know, it's very high rates and correlations between trauma and psychosis, almost as a way of the body detaching and dissociating from the experience of pain. It makes complete sense. Our body, mind, and soul are very intelligent. So just quickly, the MAD movement's key elements are around psychiatric survivor advocacy, critiquing psychiatry, and that's not to be anti-psychiatry either. You know, I'm someone that will be going to bed and taking my medication because I don't want to end up spending $10,000 tomorrow in a manic spiral, although the mania can be a gift at times and a neurodivergence that I highly regard, which fits in with the MAD Pride point. Similarly to queer pride, MAD Pride celebrates the neurodiversity and value of different ways of thinking, feeling, and being in the MAD community. And if you think about some of the greatest creators in the world, often they actually have experiences of madness. Obviously, alternatives to medicalisation, a big part of the MAD movement is alternatives. And we've already talked a lot about that around different peer support models, different community-led models, spiritual leader-led models, just basically person-centered, community-based, holistic approaches that prioritise individual autonomy and agency and don't set people up to be institutionalised or have their autonomy removed. Intersectionality, which we've already talked about, obviously acknowledging power, privilege, oppression, and lived experience leadership being a key part of the MAD movement. So that actually people are in positions of privilege, you know, or positions of power and do have the capacity. Often mental health services have very low expectations of people with lived experience, but there are many of us and many more that could do with being provided capacity building opportunities to lead in their communities. And hopefully that we see that in some of our projects in this course. Very quickly, the broader movement, just like the LGBTIQ+A movement, there are a number of different identities and positionings that sit within this. And the Global Mental Health Peer Network probably fits in the consumer user the consumer user movement, where it's more about prioritizing human rights without much of a challenge to the status quo around mental illness as the predominant philosophy of madness. The psychiatric survivor or refuser ex-patient inmate movement is more about viewing psychiatry critically and seeing it as a system of control and oppression and rejecting the idea that mental distress is purely a medical issue treated through social, to be treated, and instead emphasizing more those social, political, and trauma-related factors. And then the MAD Pride part, which you're probably less familiar with, is both a movement and an identity, which seeks to reclaim the term MAD and embraces mental health differences as part of human diversity. So it's about celebrating madness as an identity not something to be hidden or cured. So again, thinking about stigma campaigns, if people came out as mad and actually embraced that and celebrated the parts of that that actually can be quite amazing and creative and inspiring and strengths, we could see changes in stigma. So this is much more a societal and political movement, though, and seeks to emphasize issues of oppression and social norms and marginalized communities. So this
So,
led,
Matthew,
oh,
I would like to interrupt you here. I'm sorry for that, but you will have about 3 minutes left.
great, thanks. So this led me basically to founding my own social impact entrepreneur organisation, the Australian Centre for Lived Experience, being a Mad Pride think tank. Obviously, I've already talked about using the term MAD as a reclamation. Some of our activism has been around starting a merchandise line and really raising the issue around the context, creating a lot of distress. So oppression is not an illness. There's no pill for racism. There's no hospital bed that resolves poverty. These are the sorts of issues that my organisation addresses. I've been very heavily involved in a number of documents with WHO, so I'll be very quick with this. But WHO recently published, in regard to the framework for meaningful engagement of people with lived experience, a quote where I said that my bipolar is a part of who I am. It's a spiritual gift that's been brought through family, community, and societal trauma. It's a special gift in the face of consistent adversity and constant hypervigilance, but it's also a gift that requires harnessing. Sometimes that harnessing does involve psychopharmacology, so I'm certainly not opposed to pills. Obviously, I'm a big believer in lived expertise in public health and people with lived experience working in structured determinant work. And these are some of the documents that I've been involved in with WHO around peer support services, person-centered human rights and community-based services. I was one of the 12 case studies that led to the framework for meaningful engagement of people with lived experience. So it was called the Intention to Action series. These are some of the documents. You can have a look at them. So that third one, the people power, there's my case study along with 11 other people with non-communicable diseases. So there were 2 of us with psychosocial disabilities, and it has a very strong mental health focus. So that final framework is a really useful framework for member states on how to engage meaningfully with people with lived experience, which includes paying them and paying people for their expertise, which then resulted, of course, in me getting a consultant role and being paid for my lived expertise. So I'm not going to go into the framework because in the interest of time. But basically, they did co-design and produce regional focus groups. They analysed these focus groups around the world and did dyadic interviews. They interviewed 2 people at a time based on 6 case studies. So I was interviewed with Olga Kalina, who's the European user survivor of Psychiatric Network co-lead from Europe. And as you can see, there were people from Africa, from the Middle East, from UK, US, Latin America, basically everywhere around the world, the 12 case study that informed, the theme. So I focused on exclusion and the importance of involving groups that are marginalised. I'm not going to go into that. I'm grounded in disability justice principles, and you can have a look at those and probably hopefully have some resonance around leadership of those most impacted, anti-capitalism, cross-movement organising, interdependence, collective liberation and access. And I'll probably just finish on this quote. So my vision for the future within this particular case study was what we really need is natural healers in our communities. We need peer support, strong families, strong communities. We need social justice, allied health, non-diagnostic ways and methods to support us mad folk in distress. We are the data, we are the science, people with lived experience. And I can't stand it when they say there's data and there's lived experience. There's no binary. We are the science. The reality of the mental health system is that it's colonised and patriarchal, and it's designed to entrench those of us that are oppressed in oppressive conditions. Everything's blamed on the individual. They're depressed, they're suicidal, they're bipolar, they're schizophrenic. The reality is that many of us actually live in unjust conditions and as a result live in a lot of distress and expressions of distress and trauma, which then get medicalised. We need whole of government, whole society responses and sustainable economic models and systems that move away from hierarchy to inclusivity and partnership. And we need, of course, the basics: empathy, love, compassion, culturally led, community-driven, socially just-based communities that talk about power and how to share power. And there's just a ladder of epistemic injustice, which just talks about medicine being the most privileged knowledge base, which I think is the wicked problem that I'm trying to investigate with my PhD, where I'll be running regional focus groups around the world with users and survivors and mad folk in every region to find out what the mad or what this movement looks like in different cultural contexts and to see whether it even is a movement. And that's basically the basis of my PhD at the University of Sydney. So my final question is, what's your wicked problem in society? Will lived expertise ever be valued in modernist societies where one truth and privilege of biomedicine is often viewed through a psychiatric epidemiology? Do we need to think about reform versus abolition, where psychiatry has carceral power, where institutionalization is rampant in low and middle income contexts, but also in the community and high income contexts, where there's human rights abuses and social injustices and oppressions that are medicalized as disorders and illnesses and diseases? So my society is my disorder is society. And finally, education is the practice of freedom, which means, men, women, people deal critically and creatively with reality and discover how to participate in the transformation of the world. So hopefully by all of us attending this course, knowledge is power, and collectivizing is really important. So thank you very much, and look forward to your questions.
Thank you, Matthew. You can, everybody, you can ask your questions and raise your hands in between to ask your questions.
So we have Sylvia, Neha, and there's one more question in the chat. Sylvia, I'm sorry, were you meaning to say thank you? Okay, all right. All right, Neha, would you like to go ahead?
Hi, Matthew. Thank you so much for your presentation. Thank you so much for sharing the story with us and getting us clear with to it. And I don't know, this question might be misplaced. I don't know. It's just something that I keep thinking about, whenever I read about the MAD movement or whenever I come across it. I feel like, just a question, do you feel like there are certain factors that allow people to be able to afford MAD pride or embody? Because why I ask this question is sometimes I feel like people belonging to LMIC, at least people in India who live with mental health challenges, it might be very difficult for them to embrace MAD pride because they're constantly surrounded by an environment which is so oppressive, so stigmatizing. We're talking about mental health is such a taboo, right? So yeah, just a question about that. Do you feel like there's certain factors, just some access privileges that allow people to embody and embrace MAD pride?
Yeah, it's a really great point. And I think absolutely privilege and access and being in more affirming environments, which is not just family, but community and society, enable you to be in a position of privilege to find pride in your identity when you're not surrounded by shame, because of course, pride is the antidote to shame. However, that doesn't mean that mad pride doesn't exist in, a lot of Asian contexts. I've met a lot of groups and communities that do find pride in low and middle income contexts. So it's not that it doesn't exist, but I think you make a great point that in more highly oppressed communities, particularly around race and class, gender, even like thinking about regional and rural communities as well, where lynching and things like that is very common in mental health communities. It is absolutely very hard to find pride in something that is so demonized and sometimes literally demonized. People are literally experiencing exorcisms around the world that are still, because madness is culturally grounded in religion. So yeah, you make a really great point. And it just speaks to the complexities. It's not that there's any one truth, and I'm not a proponent of any one truth. In fact, MAD studies is about understanding all people's perspectives on madness, whether that's particularly from cultural and spiritual explanations. So yeah, I hope that answers the question.
Thank you so much.
Any other questions or comments from anyone?
Jenna, do you want to reflect on